May 8 வந்து நாங்கள் அதுக்கடியில் மதன் சார்ட்ட பேசி கேட்டதுக்கு எக்மோ ஒரு தான் ஆப்ஷன் அப்படின்னு சொல்லிட்டாங்க. ஆனால் எக்மோலேயும் நிறைய டிஃபிகல்ட் இருக்குது, இவ்வளோலாம் இருக்குது அப்படின்னு சொன்னாங்க. நாங்கள் எதாக இருந்தாலும் பரவாயில்ல, நாங்கள் அட்மிட் பண்ணுங்கன்னு சொன்னோம். May 8 வந்து அட்மிட் பண்ணாங்க. அட்மிட் பண்ணி மிட் நைட்டு ஒரு 11:30க்கு வந்து சார் சொன்னாங்க, ஓரளவு நார்மலாக இருக்காங்க, எக்மோ போட்டாச்சு அப்படின்னு சொன்னாங்க. ஓகே சார். அதோட ஒரு 3 டேஸுக்கு அப்புறம் அவங்க கண்ணு முடிச்சு நல்லா இது பண்ணிட்டாங்க, நல்லா கான்சியஸ் வந்துடுச்சு. அது வரைக்கும் ரொம்ப மயக்கத்திலே இருந்தாங்க, யாரையும் எதுவும் பார்க்கவே இல்லை. அப்புறம் அதுக்கப்புறம் ஒரு நல்லா ரெக்கவர் ஆகி ஒரு 15-20 டேஸுக்கு அப்புறம் ஓரளவு நல்லா ரெக்கவர் ஆகி 31 டேஸில் எக்மோவே எடுத்துட்டாங்க. அதுக்கப்புறம் ஒரு 1 வீக்ல எங்களுக்கு டிஸ்சார்ஜ் பண்ணிட்டாங்க, நேராக வீட்டுக்கு அனுப்பிச்சிட்டாங்க. பால் சார், மதன் சார், சுந்தர் சார், செல்வி மேடம், இவங்க எல்லாருக்கும் ரொம்ப தேங்க்ஸ். ஏன்னா அவங்களாம் அவ்வளோ பெரிய
undergone ECMO treatment at Apollo hospitals during the second wave of the pandemic. I want them to share their experiences with you. Firstly, we invite Mrs. Vimla Rani, a homemaker from Chennai. She was on ECMO treatment for 33 days and her total hospital stay was for 43 days. Over to Vimla Rani. Vimla ma. வணக்கம்மா. வணக்கம், பேசுங்க.
வணக்கம் சார், நான்
வணக்கம். வணக்கங்க ஐயா, பேசுங்க.
நான் வந்து பிரைவேட் ஹாஸ்பிட்டல் ஏப்ரல் 27 வந்து எக்மோ அட்டாக் ஆச்சு. ஒரு 10 டேஸ்ல இது கோவிட் அட்டாக் ஆச்சு.
My name is Madan Kumar. I am going to give you a brief idea about the ECMOs, what we have done, and also how we manage the COVID patients, how it is different from non-COVID patients, and the key for our success. Slide please. So overall we have done around 270 cases, 270 ECMOs, of which 240 almost we did before this COVID, and 23 in this second wave of COVID. So first slide please. So survival on date is around say 17 patients is surviving today out of 23, which is almost to 74%. Slide. So COVID patients managed with ECMO in the second wave, how they performed are, there are 10 patients who have got discharged home and doing successfully well, and there are 2 patients who are off ECMO but recovering in the hospital. In due course they will get discharged. On ECMO there are 4 patients. Transplant is given to 1 patient. That's what Dr. Paul Ramesh also was saying. So this is only a very, very minor population where you need transplantation. We have to identify that population and do it. So COVID is not only a disease of the lungs, it is disease of the entire body. So when you operate on these patients, when they are actively having the disease, the outcomes are poor. So that kind of patients needs to be identified and then taken up for transplant. And we have lost around 6 patients. Slide please. So how this COVID patients are different from non-COVID patients who are maintained on ECMO. First thing is, even though we know something about the COVID, we don't know a lot of things about the COVID. So the understanding about the disease is very less. So few of our patients who are referred for this ECMO and all are referred to us for actually for a lung transplantation. But after carefully studying the CT scan and other things, we thought this lung will recover and manage with our multidisciplinary team, and we are able to get them out of the ECMO successfully. So also, as I told you, this is not only disease of the lung, it is disease of the entire body. So we need a multidisciplinary team of doctors, especially GIT, heart and kidney will give some trouble. Accordingly, we need to manage them. Other thing which differentiates COVID from non-COVID patients are, for example, you would have heard of the swine flu. Those patients, we have placed ECMO on those patients, but they will tend to recover within say 9 to 14 days time. And that's it, the management is very simpler. But this COVID patients and all, on average duration is somewhere around 60 days. The people have recovered within 36 days and some people have recovered after say 116 days also. So patience is very important, and managing these patients for longer duration is also very important. So as Paul Ramesh said, we need 24/7 care. and the oxygenation to the patient are all done by the ECMO machine, and even without oxygen for a few seconds, the patients may not tolerate. And the longer the duration, the patients may have bleeding and infection. We need to attend to that also. The circuit change, what I mean is, after all, the ECMO is a machine, so it can't replace the God-made lung. So ECMO circuit may come for around, say, 14 days. Some people may come for around 3 weeks' time. So when the patient goes on for, say, for example, 6 months or so, they need a circuit change, which means we have to stop the ECMO where there will not be any oxygen to the patient's body, and then we need to change the circuit. So some patients will not tolerate even for 30 seconds also. So our team is very efficient in changing the circuit with a track record of around 14 seconds to change the circuit to a maximum of around 26 seconds. Also, we practice awake ECMO. So these patients are awake, and they are, before this COVID event, they will be having their normal life. Suddenly they got into the COVID and in the ICU, awake. So these patients have a lot of mood swings, and they need a lot of intense psychological support, not only to the patient and also to the attenders. We are blessed to have Dr. Silly in our team who does this job very well. Slide please. And ECMO is not only a one-man show, it's a teamwork. As Dr. Ramesh said, there are various departments are involved here. Starting from the surgeons to the pulmonologists to the perfusionists to the physiotherapists, so nurses and nutritionists, and also the ward boys. We are blessed to have 143 people in our department to do this, thanks to our Apollo management to provide with this amount of people, so that we can give this result to the patient, to our patients. Slide please. So one success is the multidisciplinary team. What we have, we are very proud of it, and we are able to manage these patients with it. Other major thing what we believe is we practice awake ECMO. So we will not keep the patients sedated and paralyzed on the ventilator with the ECMO till the lung recovers. That has got uniformly poor results, and there are a lot of papers to support that awake ECMO results are better. Even though it is difficult for us to maintain the patient on the awake ECMO, the results of awake ECMO are better. Once we initiate the ECMO, first we'll make them to we'll stop the sedation, make them to be awake, and then we'll pull them off the ventilator, and so that they can eat normally, interact with the relatives normally, and then they can cooperate with the physiotherapy, so that your muscle weakness and where other things will be less. Next slide. Next slide. So our physiotherapists are wonderful, doing a wonderful job on these patients. This is one of our patients getting chest physiotherapy, where patients are allowed to do breathing exercises, and they are clearing their own secretions. If you ventilate these patients, the positive pressure is injected into the lungs that can damage already infected soft lungs. So when they breathe on their own, the chance of recovery of the lung is very good. So that's what you're seeing here, the chest physio being given on our awake patients. Next slide. Also, like, we take care of the muscles of each and every part of the body, like hand muscles or the leg muscles, the letter exercises. These are the cycling devices what we have. With that, we encourage the patient to do the exercises. Next slide. So this is also one of the technique what we have. It is called as a co-mobilizer or else a tilt table, where we place the patient on this tilt table and make them to stand. This gives most morale of the patient to like anything, so that they'll have the confidence that they can stand and they can come back to their normal life. So this also prevents bed sores also. So this is the co-mobilizer where our patients are made to stand while being on ECMO. It's a Himalayan task, but our perfusionist sisters and physiotherapists are geared up to do that. Next slide. So when they are okay with able to stand with the tilt table, what we do is slowly we make them to sit out in the side of the bed, and once the back muscles are stronger, we'll give the support and make them to stand up for some time. Once they pass that, they will make them to walk around the unit with the ECMO. Next slide. So once the patient walks around and gains the confidence, then they will do whatever they enjoy in their life, like reading books or listening to the music, and cooperate well with the physiotherapy, and that helps us to get our survival rate in a better way. Next. Yeah, thank you very much. Now I invite Mr. Emmanuel to introduce our patients so that the patient can share their experience. Emmanuel.